All right, so we're going to talk about what's next because we have a lot to do. So Ryan just did a really great job presenting on what's been done so far, and this community has so much to be proud of. And I know it's probably hard when you're in the middle of the community to step back and realize who we are as a community. But this community, the Duchenne community, is really held up as a model in all disease communities as having really reshaped the landscape. And we have a lot of coalition partners at Faster Cures and Bio and Pharma and NORD, the National Organization of Rare Diseases, that really look to us as examples as paving the way for so much of what Ryan has shown, the benefit risk work, the guidance. Nobody has done this before, and we're a very small rare disease community, but we've shown that we are small but mighty. But we have so much more to do. And because we're moving really far into the pipeline, which is very exciting because of where we are with these pivotal trials and the products that are going before review, we actually now have all new issues before us. So I want to talk to you about what those are and what we're doing about it. So first of all, I don't know, have we seen this slide yet today? Have you guys seen this slide? So this is PPMD. This is who we are. This is what we do. And this is not intended to be an eye test. This is intended to make you really proud. So this is what this organization does. And I'm not going to go through it all, but what I'm going to talk about is the bottom right-hand corner right now. I'm going to talk about some of the work we're doing in the advocacy space. But this is what we do from research to advocacy to care to education, our clinical research, our preclinical research, our education tools, all the research tools we've developed. There is so much that we're putting out there. But what I really want to focus on is right now in this advocacy corner, I'm going to pick up where Ryan left off. And I really liked his analogy of the puzzle pieces, so picking that out too. And there are a lot of other puzzle pieces in this center pile that I'm not going to pull out right now that we could talk about. I'm just going to pull out 4 of the main puzzle pieces right now because I want to do a deeper dive into a couple of these pieces. So right now I'm going to talk a little bit about newborn screening, coverage and access, combination therapies, and 21st century cures and innovation. Because I want everyone in this room to have a sense of what these things are when we're putting out blogs and we're putting out information and we're putting out policy alerts and we're inviting you to Washington to come and talk about them. Because as you start coming to Washington now more often, there are all new reasons to engage. And when Ryan was just talking about the 3 letters that have meant the most to us for a long time, which were FDA, not some of the other 3 letters he was referencing, I'm going to argue that we have 3 new letters and a new agency that we are starting to engage in a very meaningful way, and that's CMS. And I'm going to talk about that. All right, so let's get into it. So let's talk about newborn screening. So there may be people in this room that understand why newborn screening is important, and there may be people in this room who are thinking, well, we've been identified, we're here, so why do we care about newborn screening? So as many of you know or may remember, or for many of you, when you had your baby, everything was a complete fog for a little while. If you had a baby here in the US, you had your baby tested for a number of disorders that are on what's called the Recommended Uniform Screening Panel, or the RUSP. And so your baby had a heel stick done and had blood spots put on what's called the dry blood spot card. So that's what it looks like right there. And what we are doing, what we are working towards, is that there would, in the very near future, be a punch, almost looks like a hole punch, taken out of one of those blood spots that would then be tested and screened for the potential for Duchenne. Sent to a state laboratory and screened for Duchenne. Because what we want is to be able to pick up Duchenne in the newborn stage and not have families have to go through the diagnostic odyssey that probably a lot of people in this room went through. But it's a hard lift. It's not an easy thing to do. And there are a lot of things that have to be in place in order for that to happen. And the reason for that is that newborn screening is a public health system. So a condition has to be considered treatable in order to be added to the federal newborn screening programs. And already there are a number of conditions in this country that are considered treatable that are not on the RUSP, or the Recommended Newborn Screening Panel. And there are right now, and there's a lot of inequity. So in some states there are 21 conditions on the RUSP, and in some states there are 34. So in this country, some of whether your child has a very severe condition or lives or dies depends on what state you're in. okay? So there's a lot of inequity. And so in order for us to have Duchenne added to the RUS, we have to, first of all, have a blockbuster treatment. We have to be able to argue that we have a treatment that would be able to be given to newborns. We also have to have a test that's very inexpensive and that eliminates the frequency of false negatives and false positives, because we certainly wouldn't want to take a family down the road of the potential of having Duchenne if their newborn was not going to have Duchenne. And we have to have a really good support system in place for the identification and the outreach for this family once they've been picked up in the birthing hospital. So we want to make sure that the people who'd be talking to them in the birthing hospital referred them immediately to a care center that could talk to them and that was working really well in sync with the state health department. So there are a lot of pieces to this. Now, I want to go back to this issue of treatable. So this is a little bit of a double-edged sword because it takes a long time to work through this process. Okay, so let's say one of these products going through review right now was approved really soon in the next calendar year. We are not going to be able to get a condition added to the RUSP within the next 12 months after that, because there is a long process to get this done. We have to do pilot studies. We have to do a lot of work. So we're doing that legwork now so that we can try and shorten the time between when we have a blockbuster treatment and when we get something added to the RUSP. But in the meantime, we, the Duchenne community, believe that we can make the argument that we already have a treatment, that we have too much of a delay before we can offer it to families. Because I just pulled up some stats for you, that in Duchenne Connect, we show that the median age of diagnosis is 4. And then from CDC, the MD StarNet stats, so that's our national surveillance data, that the mean age of diagnosis right now in this country is 4 for Duchenne. And we are right now, there's a clinical trial underway showing some efficacy in offering steroids to boys as young as 2, maybe even younger. And we know that people are not being offered steroids until much later than that. But if we're not picking people up till 4, they wouldn't be offered until earlier. So already, the standard of care in Duchenne can't be offered to people until much later than we know the standard of care is to offer it. So the argument we can already make to the newborn screening panels is we have a treatment before there's a new approved treatment that can't be offered to boys. So all that to say, we're moving forward with expanded pilots. There was one pilot that was very well done for Duchenne in the state of Ohio, and we're looking at expanding those pilots because what we have to be able to do is replicate that pilot and get the numbers up and show that we can do what Ohio did in more states in a controlled way. So we're working on that, and we're doing that right now. So we have a whole metric for how we're working that out. We're building the infrastructure, we're building the resource materials, we're working with many of the people who sit on what's called the Secretary's Advisory Committee for Heritable Disorders in Newborns and Children. We're working with the people who write the legislation, which is the Newborn Screening Saves Lives Act. And we're working to refine the diagnostic assays because it's a 2-tier test, right? There's a CK, and then there's a molecular assay, so that we can reduce the false positives and false negatives, and we can reduce the cost of the tests. And we're working with all the federal agencies that touch this process. In order to do this, we have put together a steering committee, and PPMD brought on a woman named Michelle Puryear, who I don't know if she's in the audience today or not, who is one of the world's renowned newborn screeners and used to be on the Secretary's Advisory Committee of Newborns and Children, and she's come on as a consultant who is working with us to lead this effort. And you can see here who's on the steering committee to help drive this pilot. So we started this in January, and we formalized the steering committee I think about 2 weeks ago. We held a meeting in the end of January with many of these people and many other federal officials, and we're really driving this effort forward because we don't have time to waste, because this really needs to line up with when we see product approvals coming down the line. So I just tell you that to give you some background and tell you those are some of the things that we're working on to really reshape the landscape. Other issues that we're working on when you talk about landscape reshaping: combination therapies and coverage and access, because at the end of the day, we're not here just to see new great treatments approved. We're here to get them, right? We want access to these therapies. So let's talk about those again. So we need to talk about what happens between the time when something gets approved at the FDA, because now we can actually envision a day when that might happen, which is really thrilling to even think about that, and when it ends up in your medicine cabinet. Because it turns out there's a whole process for that to happen. All right, so we go back to this pipeline. I'm only going to show you page 1 of the pipeline, not both pages. And as Jill Raphael Fortney talked about earlier, we're really interested in combination therapies. And just by show of hands or beep of the horn, how many people here take more than one medication now? Right. So we're all already on a combination of therapies. Okay? So the reality is that when products are approved, you're going to want access to a combination of therapies. And so we're very interested in creating an evidence base, meaning we want the payers, your insurance companies, to be approving a combination of these therapies also. And we want to figure out how we do clinical trials to prove which therapies in combination are efficacious. And we want to make sure that when these therapies go through the pipeline, they're approved to you in combination. And there's this whole algorithm for the payment and reimbursement infrastructure. And you can see this, they call it the cure to care continuum. And we're at the start, the FDA here at the top, which is very exciting because it took us a long time to get there. It used to be we were down at this idea at the bottom. So Ryan sort of took us through what it took us to get to the FDA. And we have a lot of things that are still working through from idea to FDA. And we're going to keep feeding this pipeline. But before we get to the H, we have a lot more to do to get around to coverage. And so we at PPMD are working that other side of the space. And you'll hear a lot more about that from us, about what's happening on the other side of this. And you're going to see more policies coming from us and more legislation coming from us that we're working on to work this other side of it. But we just want to give you a context for what that's about, because we're looking at it for you. We're watching this landscape for you. So we've heard a lot about this. We have a lot of colleagues and partners in the space, and you've probably read a lot about what happened with Sovaldi in the hepatitis C community, which I spelled wrong, and the CF community with Kalydeco and lumacaftor, which they're looking at now in combination. So we've had a couple communities that have had really big, exciting breakthroughs. I mean, game-changing breakthroughs, which have been amazing for our sister communities. But they're also really important lessons for us as we look at access and engagement with payers. And so what we need you to know is that PPMD is working with those communities to understand the lessons learned and what we need to be doing to collect better data for our evidence base. We work on a coalition of partner groups that are looking at these issues so that we can make sure that we're working smarter and are prepared. And then just a couple things for you to think about and to know about so you understand some of these issues. First of all of the work that we've done, the benefit risk work, all of the guidance work, all of the data that's in Duchenne Connect, that's not just information that we need for an FDA approval. It turns out that's also information we need to be able to take it to a payer group at the CMS and justify that these drugs matter and that these drugs, and we can justify the cost of these drugs to your insurance company so that your insurance company will hopefully add them to your insurance profile. So all of this will help us with that next set of letters that we have to work with, which is really important. And there are some additional outcome measures and some additional surveys that we're going to be probably layering into Duchenne Connect soon that we're going to be asking you to answer because CMS is advising us to add those. And so we ask that when we come to you and ask you to fill out something extra, we know it's extra work, but we're trying to prepare our community to be ready for the next step. So that's the first part. The second part is that drugs that are expensive end up in what are called specialty tiers. Okay? The more expensive a drug is, the higher the payment tier for that drug. And then they work with specialty pharmacies. So you don't necessarily go to your local CVS. You might go to a national distributor. And so all of our drug companies and all of our industry sponsors in the space are also preparing and working with specialty pharmacies and talking about who's going to be available to manufacture their drug and then which specialty pharmacies are going to be working with our patient community and how they're going to message that to the patient community. So you're going to hear more about that. The issue for you is going to be your insurance is probably not used to hitting its cap in January. So everyone in this room is probably really good at navigating your DME benefit, right? You're masters at that. You know how to look at your policy, and if your company calls you tomorrow and says, hey, we're switching insurances, you know exactly how to flip through and see what the DME benefit is, what your copay is, what of your out-of-pocket expenses, you're going to have to start looking at new sections of your insurance. And in our partner communities that have had to, for a long time, deal with pharmacy issues, they're really adept at dealing with the pharmacy costs. So let's look at Hep C for a second. Or even look at arthritis, or look at juvenile diabetes. Those are drugs that are very expensive. Those are drugs that work very effectively, and they're certainly worth the cost of the drug, so we're not contesting that at all. But if you are on a combination of drugs or one drug that, let's say, costs $100,000 a year, you don't have to pay $100,000 a year out of pocket, but it is a reality that could potentially be what it costs your insurance. But what that means is that your insurance has a cap on it. And thanks to Obamacare, there are caps on your insurances now. And it's usually $12,000. But that means you're going to hit your cap in January. And you're going to have to be prepared to pay $12,000 in January. And that's something we're not used to. Now, there are legislative efforts that are now working to try and spread those caps out over 3 months so that you don't have to write that check in January, but you can write it out over January, February, March. But insurance is legislated on the state level, which is a part of the reason why Ryan and I and PPMD launched our state advocacy program, so that we could start to get used to developing state-based legislative relationships. Now, we started with our federal legislators on the state level, but to start to engage all of you on the state level. So we encourage you to get involved in these programs, because very soon we're going to start dealing with a lot of state-based issues, because they're going to be insurance issues. So I say all this not to scare anybody, because we're in a brave new world, and this is really good, and this is a place other organizations have been before, but we're ramping up. And so there's a method to our madness. So when we're laying on new surveys and we're pushing out new programs, it's because we're getting ready, and nobody advocates like the Duchenne community. So we're going to take it on and we're going to get it done, but we just want you to know what we're working towards. All right, everybody with me? All right. So let's talk about how we get things done, because we're going to do this tomorrow and we're getting it done. And I'm going to tell you about how PPMD gets stuff done. So those of you who were here with us in February may remember us talking about 21st century cures. How many people were here in February? All right, so this is going to be a review for some of you. So 21st century cures. So these are our friends Fred Upton and Diana DeGette, who are from U.S. House of Representatives, and they lead the Energy and Commerce Committee, and they've been leading a bipartisan effort around 21st century cures, which is looking at the drug development pipeline all the way from discovery to drug delivery. And they started this a year ago, last summer, and they have really, this has been really a breakthrough effort where they brought academics and industry sponsors, and they've brought private companies and patient groups in, and they've said, where are the problems? Where are the stopgaps? How do we make this faster, better? How do we get therapies delivered into patients? Where are the problems? And then they gathered ideas from patient communities in the form of provisions, and they gathered them from industry in the form of provisions. And they put out a lot. There's been a lot of social media over this. I think there are probably a lot of us in the room that get a lot of their social media every day. And we had a provision that we pushed forward. And our provision didn't make it in. But a lot of provisions that we supported did. So those of you who were here in February heard us talk about our provision. And our provision was called PFIA, and I'm going to talk about it in a second. So that was the House version, and that's moving forward, and we are very supportive of the 21st Century Cures effort in the House. And we want to see that go because we think it's a really important idea and has a lot of important money for the FDA and the NIH and really important tools moving through it. But what we want to see go also is our provision, which didn't make it into the 21st Century Cures Act. Not because there was any problem with it, not because anyone had pushback. And what they told us was, we really liked your provision. It really helped us shape what they called their patient-focused drug development section. And we took a lot of your ideas. But we just had a lot in our bill, and it just, at the end of the day, didn't make it in, which we get that. So the House has their brand, 21st Century Cures. Now the Senate has their brand. Same idea, same concept, but they're calling it the Senate Innovation Initiative. So it's kind of like Coke and Pepsi, all right? So the Senate Innovation Initiative has just started. So again, looking at the whole pipeline, development to delivery, And it's just started. So they haven't even finalized what their buckets are going to be, but we know there's a drug development bucket. So, but this time, we know we are determined to get our provision in there. So we're not just going to go to the Hill and talk about it as a good idea and that we really want it. This time, we're going to drop a bill. And we're going to give it a bill number, and we're going to go and we're going to collect co-sponsors, and we're going to get enough momentum behind it so that at the end of the day, when innovation and 21st century cures have to reconcile before it passes, we've had this standalone bill that's had enough senators and momentum on it that we get it into the final package. So we're going to drop a bill. So we're not just going to drop a bill. We did it today. So while we were all here today, we dropped a bill. And so our bill is called the Patient-Focused Impact Assessment Act, and it is S-1597. And we're very grateful to Senators Wicker and Senators Klobuchar for sponsoring the bill. And when we signed the bill on today, we signed it with, in addition to our 2 lead sponsors, we have 4 original who are leading it, who are all on the HELP committee, the Committee of Jurisdiction. This is a big deal to do this. And the originals on are Johnny Isaacson from Georgia, Al Franken from Minnesota, who's actually a new champion for us, Susan Collins from Maine, who is not a new champion for us, she's a longtime friend, and Michael Bennett from Colorado. And those 4 are all on the HELP committee, the Committee of Jurisdiction, which will really help us. So I'm going to tell you what that bill is. I'm going to tell you what our ask is tomorrow. But when you go to your Senate meetings tomorrow, we are going and asking other senators to sign on to S-1597, the Patient-Focused Impact Assessment Act, which we want to have incorporated into the Innovation Initiative. And we have a very healthy, respectable list of Senate leaders who are leading this effort for us. And this is something that, again, our Duchenne community does not take no for an answer, and we find a way to get it done. So let's talk about what PFIA is. So PFIA is, you've heard about all these great tools we've created, that we are industry sponsors, that we, PPMD, have created benefit risk, Duchenne guidance, putting patients first, Duchenne Connect, patients are waiting. We spend a lot of time and money and resources on this whole category called patient-focused drug development tools. And the only reason we've created these tools are so that when products go through review, the reviewers know what these drugs mean to us, right? Because we're all not allowed to be in the room with the reviewers looking over their shoulder saying, that means something to me, right? That outcome measure will change my life. We can't be there, but these tools can reflect that to them. But we have no way of knowing whether or not all these tools that we've now put in the toolbox, in the language that we've been asked to put it in, that have been validated for us, are actually going to be available to the reviewers at the time of the review. So all we want is a checklist, a simple checklist. It can be a simple piece of paper that a reviewer checks at the time of a product review. It has no bearing. It doesn't change the way a product's reviewed at all. It doesn't touch the product review at all, but just a checklist that is completed at the time of the review that says, were the following tools used? Yes, no, not applicable if that tool doesn't exist. Was benefit risk, patient preference used? That's applicable to blank community, because this isn't just for Duchenne, right? Any community that's created tools can use this. Yes, no, not applicable. Was expert input from experts who know about insert name of disease, Duchenne, used? Yes, no, not applicable. And we just want a checklist. And then we want that to be published. And at the end of the year, we want aggregate data to know what tools were used. We want a feedback loop. That's all we want. We want transparency and a feedback loop. So we know, first of all, whether it's worth all the time and energy and resources we're putting into this. We just want to signal back to know if what we're doing is making an impact. So that's what we're asking for. And so putting it very simply, the ask that you're going to be asking for tomorrow, after you've told your story, and we're going to talk more about that, is that we want to create a feedback loop between the FDA and stakeholders, that would be us, that would be industry, by creating the PFDD tools checklist. And PFDD is the Patient patient-focused drug development checklist by co-sponsoring S1597, the patient-focused impact assessment. We just want to know that the tools that we're putting in the toolbox are useful to the reviewers. We're not even mandating that they go in with a product review. We just want a sense that those that are there are being utilized. So that's what that is. And I'm just going to say thank you. I'm going to put this slide back up. And I'm going to introduce Anessa Faisenfeld, who is our chair of our board of directors, who's going to talk a little bit about advocacy and what it means to her and what you're going to be doing tomorrow. So I just want to say thank you to all of you for being here. I have the privilege of getting to represent our community almost every day on the Hill, and to all of our federal agency partners. I have the best job in the world because you are such an amazing community, and it is so exciting to have you here in Washington doing it with us. So thank you very much.